Washington, D.C. is my home away from home. I've worked here for the better part of 3 decades as a founder, entrepreneur, policy expert, and author.
Probably the longest title. Everybody sort of shortened it to ONC for sanity's sake.
Mercifully.
Yeah, mercifully.
I've learned leadership secrets from many healthcare executives who understand that Washington is the largest payer and regulator of healthcare.
She said, well, because you'll never get a husband if you do that.
I began interviewing healthcare leaders many years ago because what better way to learn how they think, why they make it to the top, and how they remained there. Think about what was your most challenging engagement.
Healthcare has been the most difficult problem. Let me just say that.
We'll talk about that later. In 2019, Americans spent $3.8 trillion on healthcare, accounting for about 18% of America's GDP. According to CMS, healthcare costs are expected to reach $6.2 trillion in 2028. Healthcare affordability will be the defining challenge of this decade. For this special episode, we'll examine the challenges of affordability. To begin, Dr. Mark Miller, VP Healthcare Arnold Ventures, will start the conversation on why affordability is an important issue. Then, we'll hear from 4 other healthcare experts to discuss potential solutions. We will hear from Dr. Marty Makary, Johns Hopkins surgeon, health policy expert, and author of The Price We Pay, who will dive into cost savings in Medicare. We will hear from 2 healthcare professionals on Medicaid. Nancy Ann DeParle, who is managing partner and co-founder, Consonance Capital Partners, and former assistant to the president and deputy chief of staff for policy in the Obama White House, will discuss California's Medicaid model. Seema Verma, former administrator of CMS, will elaborate on Indiana's Medicaid model. To conclude, we'll hear from physician and retired General Elder Granger, former deputy director of TRICARE and CEO of the 5 Ps, who examines the affordability of TRICARE. To begin, let's listen to Mark Miller on how healthcare costs burden patients.
I do think the affordability from the perspective of the taxpayer, an employer, a family, will be, the defining issue. And the question will be how we ultimately come to that, whether it's the sustainability of Medicare and, even recently outrunning the HI trust fund and the fact that Part B just draws from general revenue and how sustainable that is. The employers, if they ever would, wake up and realize that this is something that they have to address, that it's eating their budgets. And when you have, 40% of American families unable to get together $400 in an emergency, we've got to do something, because having, the way the health benefit is moving because of the costs that I'm referring to, they become much more, they're pushing much more onto the consumer through deductibles and copayments that they don't have. And so that reckoning feels like it has to come to a head.
I agree, affordability will be the issue of the decade. I don't think there's any way out of that. It looks to me, Mark, like there's a shifting of risk from the employers and the payers to the consumers and the providers. Do you see that? Would you agree with that formulation or not?
No, I do agree with that. And I think the way the providers have responded to it is to consolidate and extract, in some instances where they can, higher prices, or to try and design payment systems that help them kind of protect their particular revenue stream. I think you've seen a lot of that in the alternative payment model process, where particular groups of providers will come together and say, well, let's build a payment model around what I do. And sometimes I think it is well motivated and intended to, result in a better product. But I also think there are attempts here where it's just to build a moat around a particular set of revenue. So yes, I do think that things have become less affordable for the employers. And so there has been this redesigning of health benefits to push much more on to the consumer to the extent that they can do it. So I would agree with that.
Healthcare is made more and more expensive for the consumer. The cost of healthcare in the United States is unsustainable for many Americans. How will we find a solution? Healthcare payments occur at the level of the federal government, state governments, and the individual. This adds complexity and means that addressing affordability will need to occur at multiple levels. Next, Dr. Marty Makary will discuss one method of reeling in the cost of Medicare.
Affordability is an access path. And as a matter of fact, it's the number one way to increase access and tear down barriers that we see with the social determinants of health. And so we can keep throwing good money after bad into this system. And, I open the book by showing how doctors just around the U.S. Capitol building within miles are putting unnecessary stents in leg plaques that don't meet criteria, but they know how to game the system, and Medicare is paying for all of it, to show that we can keep throwing money into the system, or we can start to get wise about using what I call appropriateness measures. That's a big project now that my team and I are doing. How do we identify practice patterns of appropriateness and maybe replace pre-authorization with gold carding providers that fall within those boundaries of normal variation? Practice variation is good and healthy within boundaries. And it turns out that when you talk to experts, they will tell you, the docs will tell you in that narrow specialty, this is a pattern that's outside of the boundaries of reasonable. It's a pattern that's indefensible. It's a pattern that's a byproduct of our fee-for-service system.
Appropriateness measures create consistency in costs as well as treatment expectations across patients. Medicare and Medicaid combined account for almost 40% of all healthcare expenditures, and both continue to grow in cost. Next, we'll hear from two Medicaid policy experts. First up, we have Nancy Ann DeParle. Segueing to the current administration, the Biden administration, what advice would you give them regarding the ACA and the moves that they're making there?
I haven't sat silently for sure. I've given them some advice, and among my advice is to look at California, to look at the states where it's been very successful, both in getting a lot of people covered and in having competition, holding premium rates down. I believe last year in California, the rate increases were less than 0.5%. So why is that? It's because California went all in. It's because California expanded Medicaid and told the plans, if you want to be in Medicaid in California, if you want to be part of Medi-Cal, great, we'd love to have you, but you also need to participate in the marketplaces for the uninsured. Mm-hmm. And they've spent their own money on doing marketing and enrollment in California. It suggests they have spent money. Even so, the so-called young invincibles have been hard to bring into the marketplace. Yep. And it does appear that one thing they've learned is that the tax credits to defray the cost of premiums and the subsidies are important. They just went through a round about a year ago of improving that in California, and it's made a difference in getting people into the market. Mm. So there's a whole playbook from California of how you go about strengthening this law. And by the way, it doesn't involve a public plan. They haven't had to do that. They have plenty of competition. So I believe that we can do that.
California's Medicaid program decreases patient costs by encouraging competition. Now, what do Singapore and Indiana have in common? Singapore's healthcare system is well known for its savings accounts. It's a model built on accountability, individualism, and cost savings. And this model was replicated in Indiana. So let's hear from Seema Verma on how Indiana expanded Medicaid with health savings accounts.
The Healthy Indiana program was sort of revolutionary and probably is still very novel in the way that it dealt with the Medicaid program. I give a lot of credit to our good friend Mitch Daniels because he really was that kind of conceived the idea of trying to do something around consumerism in the Medicaid program. And he really felt like with growing healthcare costs that it couldn't just be the insurance companies and the doctors that were responsible for trying to lower healthcare costs, that we needed to engage the patient and the consumer. And so the idea in Medicaid was to have a health savings account, which had always been poo-pooed by people because they said, well, low-income individuals can't manage an account. And, we put all of those types of claims to bed. We funded the health savings account to make sure that there was enough money. And the individuals would also put money into that account. And if there's money left over at the end of the year, they can use that money to offset their own premiums. But it really kind of instilled the concept of, if I go to the doctor, this is how much it costs. I think they tend to value the health insurance that they have. But I think those principles, the idea of consumer engagement, of consumerism, have really stayed with me. I think we tried it in Indiana. It worked very well. That program is still around. And those concepts, I think, we have seen have been duplicated across the country in other Medicaid programs as well.
There is more than one way to improve Medicaid that caters to the unique cultures and needs of different states. It's clear that the mission to decrease costs unites both left and right. Lastly, we'll hear from General Elder Granger. He discusses if the U.S. military's model for healthcare could work for the rest of the country. Many people think that TRICARE would be a terrific model for the country. Does that make any sense? How do you think about it?
I do see it as a model because the way it works is that it's built, we recruit healthy individuals in terms of the military, but when they come in with a family, when they develop a family, we take the family with all the pre-existing conditions. We put in a very strong preventative population health program that is culture-based, designed to take care of individuals from the time a baby is born until they get to a certain age, now age 26, or until you retire from cradle, what we call from cradle to grave. It is a very cost-effective program. It has all those things you need in the healthcare: access, prevention. We eliminate, to the best of our ability, social determinants of health. And then the fact that you have a strong preventative, you're not doing a lot of wait till the individual get a bad condition. They come in and needing emergency care, which is very expensive. So that is a model. Some of the things you see right now in the Affordable Care Act, no co-pays and deductibles, came from us piloting that idea in the military. And some of our populations that they had to pay a co-pay or deductible for preventative service. We eliminated it. We increased preventative service usage significantly. So I see it as a model. And plus, too, it's a model that you can basically control the cost over time.
Patients may forego preventive care to save money in the short term, but this can cost the patient, insurance, and care providers more in the long term. TRICARE provides a model for a cost-effective program that encourages preventive behavior. When it comes to addressing affordability, there are thousands of potential solutions. The catch is deciding which models work together in our complicated system. At the end of the day, healthcare is more than balanced budgets and revenue cycles. It's about caring for the patients. Affordability and ensuring that patients can afford the care they need is fundamental to the mission of healthcare. Thank you for joining us.